Good day, everyone. I am Dr. Chakan, and I will be conducting a quality improvement study to improve postoperative pain management in the recovery room as part of my DM research project. Now, it has been observed that an increasing number of patients in the recovery room complain of severe postoperative pain requiring optimal management, and that the assessment of the pain scores indicated that despite receiving intraoperative analgesia, their pain management was not adequate. So during the period September to October 2021, a pre-audit was conducted on 34 patients ranging from 11 to 89 years belonging to ASA 1 and 2 classifications. And these patients had general surgery, neurosurgery, obstetric and gynecology surgery, and orthopedic surgery under general anesthesia. The pre-audit revealed that 59% of patients reported high pain scores, a numerical rating scale or NRS score more than or equal to 4 postoperatively. The International Association for the Study of Pain states that pain is an unpleasant sensory and emotional experience that's associated with actual or potential tissue damage. And for these patients, it is one of the most feared factors in the perioperative period. Therefore, treating postoperative pain is important because if managed suboptimally, they will get a sequelae of complications such as pneumonia, atelectasis, deep vein thrombosis, and this leads to increased morbidity and mortality. Therefore, effective management will offer the advantage of increased patient comfort and satisfaction with faster recovery times and return to premorbid function for these patients. As shown here, I have received ethical approval from UWI to conduct this research project, as well as the Southwest Regional Health Authority. This is generally an outline of how it will be conducted. Initially, we will do a baseline data collection from Monday to Friday, 8 to 4 p.m. We will include elective surgery only, and it will consist of 50 patients. Then I will launch the QI initiatives, the postoperative pain algorithms, the patient information pamphlet, and have discussions with both doctors and nurses within a 1 to 2 week period before we collect data again for 50 patients. After this, I will do a performance feedback. The first one, we will raise any issues that occurred during data collection or during the study, and I will make changes to suit. And then we will collect data for 50 patients again, after which I will conduct another performance feedback where issues that arise can also be raised. Again, I will make the changes and perform the final data collection. Essentially, 4 times there will be data collection throughout this study. This is the data collection form. Part of it will be completed by the doctor and part of it will be completed by the nurse. The first part of the form will be filled out intraoperatively. It will include the patient's registration number and their patient ID code, which I will create unique for each patient to identify them without using any demographic data that will let us know their names. It will include the date of their surgery, their age, gender, ASA status, any comorbidities they may have, as well as the type of surgery they are having, the duration of their surgery, and the intraoperative analgesia they received, and the dose. The second part of the data collection form will be completed in recovery room, and once these forms are completed, they will be left in a folder that I will leave in recovery room. So we will look at the initial pain score via the numerical rating scale from 1 to 10. And this table is where we insert the time, the patient's NRS score. For the baseline data collection, this POSS is the Posero opioid-induced sedation scale, but for baseline data collection, we will leave out this part. And then we will, in this area, we will put the analgesia given and the dose. Here we will look at the side effects of the opioid analgesia, if any, the route at which the analgesia was given. Now, we all know there are some patients who are unable to give us a score, either because they're in a lot of pain or they're genuinely unable to assess using numbers. For this, we have the non-communicating adult pain checklist. And this checklist looks at vocal reaction, emotional reaction, facial expression, body language, protective reaction, and physiological reaction. And there are 4 options: not at all, just a little, fairly often, and very often. So translated onto the NRS scale, if the patient's majority of selected options are very often, we will give them severe pain NRS 8 to 10. If the majority are fairly often, we will give them moderate pain NRS 5 to 7. And if the majority of selected options are not at all and just a little, we will give them mild pain with an NRS less than 4. After this, we indicate the duration of time spent in the recovery room, the pain score before discharge, and the sedation score before discharge from the recovery room will be omitted from this baseline data collection. Any questions, feel free to ask me, Dr. Laitan or Dr. Bagauti, as we move forward with this assessment. Thank you for your attention.